Well, good evening, everyone. I am Dr. Joel Saylor. I am the Senior Professional Services Veterinarian for Merck Animal Health for corporate and strategic accounts, and it's my pleasure to be here tonight with you. Merck Animal Health is the manufacturer of Bravecto, flea and tick products, as well as Novavac Lyme, in addition to a whole host of other products for companion animals, equine, and food animals. But beyond our products, we also take part in being veterinary focused, and it's my pleasure and our pleasure tonight to be the proud sponsor of Animal Cancer Care Clinic's annual summer webinar series, How to Navigate Through the Cancer Diagnosis, of which tonight is the first one. So we're kicking it off. So I'm really thrilled to be the one to get to kick the series off tonight. Before we really get rolling tonight, though, I want to kind of play a brief video. The president of the Animal Cancer Care Clinic, Dr. Stephanie Correa, could not be here with us this evening. However, she did leave us a short video message, and we'll take a couple minutes and play that now.
Good evening, and welcome to Animal Cancer Care Clinic's annual summer webinar series. I'm Dr. Stephanie Correa, the president and founder of Animal Cancer Care Clinic, and I'm also a second-generation veterinarian. Over almost the past 20 years, we have metastasized through our great state of Florida from South Miami to Orlando, and our multi-locations have allowed us to practice our mission of caring for pets with cancer. Hope is something very special to us. It's what we give every day. And at Animal Cancer Care Clinic, HOPE stands for healing, optimism, patience, and empathy. It's what we do. And tonight, during our series, we hope to give you, our referring veterinary community, some information on cancer care through learning about the breadth of knowledge of our veterinary specialists, as well as learning a little bit about the advanced state-of-the-art technology that we now have to treat our patients with cancer. And certainly, I want to thank Merck Animal Health, our sponsor, for providing all of the behind-the-scenes work with the technology, the registrations, all of the emails that you receive. These events would not be possible without our sponsor, Merck. And lastly, remember, the best way to secure an appointment for your patient with us is by going through our referral portal at cancercarereferral.com. So thank you for being here, our referring veterinarians, and until next time, thank you.
All right. Thank you, Dr. Correa. So before we get started and before I introduce Dr. Roof tonight, a few housekeeping items. Please keep your questions until the end. You can put those in the question window, and we will save time at the end so we can go ahead and try and get all those questions answered. As you know, if you participate in the whole session here, you will receive one Florida DPR approved CE credit or certificate for tonight's presentation. You will receive that certificate within the next 24 hours through your email. So just be on the lookout for that. That having been said, I'd like to introduce our speaker tonight, and that's going to be Dr. Erin Roof. Dr. Erin Roof is a board certified veterinary oncologist, and tonight she's going to be discussing osteosarcoma, a journey forward. She will provide an overview of the risk factors and the etiology of osteosarcoma in dogs, and will discuss various methods used to determine a diagnosis and staging. She will also talk about treatment plans for owners and new exciting immunotherapies that are now available. Dr. Ruth is an avid equestrian who received her doctorate of veterinary medicine from the Louisiana State University, Go Tigers. Then she completed a rotating small animal internship at the veterinary specialist of South Florida in Fort Lauderdale. She completed a 3-year residency in medical oncology at VCA Bay Area Veterinary Specialist and Emergency Hospital in San Leandro, California, and is a valued medical oncologist at the Animal Cancer Care Clinic team. So without any further ado, I'm going to hand it off to Dr. Roof and take it away.
Thank you so much. Thanks, Dr. Saylor. So I'd like to, just thank Merck for sponsoring our series. This will be fun. You may remember me from past riveting excitement with mast cell tumors and videos on Stilfonta. So we're going to talk about osteosarcoma tonight. So I hope this will somewhat be a little bit interesting and new for you. So we've got some new immunotherapy coming out, so we're all kind of excited. So I hope everyone enjoys, and we'll do some questions at the end so I can hopefully get some feedback instead of staring at myself in a screen. So, all right. Osteosarcoma. Okay, so I know we went through this outline, but these are kind of the things I wanted to talk about. My favorite thing on this, I think, is the treatment tree. This is where I kind of really outline for especially clients, okay, you need to think this way or this way and where to go from here. So we'll definitely kind of spend a little time on that. Why does this happen? They all ask you this question. When does it happen? What are the risk factors? And every single owner is going to ask you this. It's something I just preemptively answer when they ask me, or, when I walk in the room. This is what we know. This is what we don't know. But basically, it's the most common primary bone tumor, right? We see it in the skeleton, 85% of any skeletal malignancy. When they ask me, what else could it be? What else could it be, doc? I say things like chondrosarcoma, hemangiosarcoma, fibrosarcoma, or these MLOs that we see in the skull. So when I'm looking at something that looks like a tumor in a bone, it's got some osteolysis, osteoproduction, I'm thinking cancer. There's a few other things, right? We see those severe osteomyelitis cases and fungal cases. So I say, I'm pretty sure this is an osteosarcoma, but these are the other things it could be. And here's my differential list, especially from the cancer standpoint. It occurs in quite a few dogs, 10,000 dogs, more than 10,000 dogs a year. They're usually that middle-aged, although we do see that young kind of 18 to 24 month, that 2-year-old golden that comes in lame, and you're like, there's no way it's cancer. And you take the x-ray and you're going, oh my gosh, no way. And so we do see this kind of bimodal age distribution where we'll have young dogs and then those old 7 to 9-year-old dogs. It's usually our large to giant breed dogs, right? They're huge, greater than 40 kilograms, and kind of the list of breeds there. Risk factors. We've tried to really look at this, and you've now all read some of these papers, but the Rottweiler paper with the males and females undergoing, sterilization at a very young age, they had an approximately 1 in 4 lifetime risk for bone sarcoma. So are they going to develop it? Maybe 1 in 4. They were more likely to develop the bone sarcoma than dogs who were sexually intact. So again, that conversation of when do you neuter, when do you spay, it's a tough one. I don't have a good answer for it anymore. When I'm talking about a large breed dog that's getting older, especially a male, I'm thinking maybe we can wait, but it depends on their lifestyle. Are they going to let that dog go out and get hit by a car and breed and do other things? Versus a female who now, if I'm waiting on my spay, am I increasing my risk of something like, mammary cancer, which we know. So it's a tough conversation, and I my heart goes out to you because you're having it much more than I am, but it's a tough one, and I don't know what's right and wrong for some of these patients. Maybe more studies in this area will really help. So most of these occur in the appendicular, right? Long bones, and a few of them will occur in the skull and axial skeleton. These usually occur in the metaphysis, right? So if it comes in with a, mid-diaphyseal lesion, I'm actually thinking that's a MET, not a primary bone tumor, because that nutrient foramen comes right there, right in the middle of the bone. So if I have a lesion right in the middle of the metaphysis, I'm really thinking that this is probably a metastasis from somewhere, a secondary tumor versus, a primary bone tumor, where I'm thinking that that's going to be, down in one of the metaphysis regions. It's usually in a thoracic limb over a pelvic limb, but we see them both, obviously. And then you've seen this picture, you've heard the comments away from the elbow towards the knee. So those are our practical sites. When I get a patient in, when it's not the right site or not the right bone, let's say it's a proximal ulnar lesion, that's the case I'm going to go find out more information. Does this fit with a bone tumor? So when it's not the right location, not the right breed for some reason, that's the one I'm going to probably do more diagnostics in to find out what's really going on. So again, kind of, or how much does this happen? Interestingly enough, the multicentric, so, I have bone cancer in 2 different legs or in another place. They, owners ask you this all the time, are they going to have it in other places? It's less than 10% of cases. So that multicentric case is really rare. We don't see it very often. And then some patients will develop osteosarcoma in non-skeletal locations. So that mammary gland mass occasionally will be an osteosarcoma. We sometimes see it in the spleen, cut it out and go, wow, what is this? I will say these extraskeletal osteosarcomas are really aggressive. So when I find bone cancer where there isn't bone, it's usually not a good sign. Okay, why does this occur? We don't know. I always, everyone's gonna ask you, you're gonna respond, but a lot of people have looked at a lot of different things, physical factors. So again, someone said maybe it's a virus through the litter mates. That really hasn't proven. A lot of people thought about micro damage to the physis during the growth phase. So these dogs grow really fast. They're huge, large breed dogs. They're growing really quickly when they're very young, and maybe we're getting a lot of micro damage. A study that looked at this found really no difference in the micro damage on cadavers in the radii, but of small and large breed dogs. They all had a similar amount of micro damage. So maybe not this. Metallic implants. This accounts for about 4 to 5% of osteosarcoma formation. So this is your question. You're doing your TPLO and you're putting in a metallic implant. Do you talk to those clients about the risk of potential, osteosarcoma formation in the future? Do you say it's a 4 to 5% risk over their lifetime? You saw the median, time to diagnosis. We've got 2 to 5 years kind of in there where these happen. So it's not going to happen right away. It's going to happen many, many months later. Is it something you warn your owners about or not? And I need to ask my surgeons if that's something they talk about when they're talking about, implants, and especially long-term implants, whether they even talk about this risk. It's super low, right? 4 to 5%. That's not a lot of cases, but it is a potential risk. And if you're putting cerclage wire in a young puppy, is this something you mention that they have a potential risk for developing osteosarcoma later in life? Good question. Ionizing radiation, we see this in people, obviously it's proven, and then exposed to plutonium. And then we talk about it as a late radiation complication. Again, it usually happens years later, and the incidence is less than 5%. So again, rare, proven, we see it. We generally talk about it and discuss it as a possibility. Genetic factors. I think this is where a lot of research is going into. We've got these P53 gene mutations. We're looking at a lot how this affects it. How does this lead to osteosarcoma? They've looked at retinoblastoma, P10. There's likely a ton of factors, but I do believe the research here will likely get us to those, more targeted therapies that we really want, the ones that target the tumor cells and avoid attacking just all randomly dividing cells in the patient, right? Where we can leave the normal patient cells alone and we can attack tumor cells. So a lot of different genetic factors. I hope we can elucidate more and more over the future. Similar in line, these pathways. So this is where a lot of the research is going into these different pathways that are mutated. So we've got this MET pathway that's mutated, insulin like growth factor, mTOR, so this mammalian target of rapamycin, often mutated in development of osteosarcoma. We actually have an mTOR inhibitor, out there. So how does that drug play into treatment opportunities and things like that? Again, these looked at, hedgehog and notch pathways. We've looked at HER2. And the big thing is, on my picture is as we elucidate these, as we figure out what is causing it, what the pathways are that are abnormal, that are dysregulated, then we can make drugs against those pathways. And these are the drugs that are going to be much more targeted. They're not going to have as many side effects, and they're probably going to potentially work better than a lot of our, general chemotherapy drugs that attack all rapidly dividing cells. Pathology, so this is that mesenchymal tumor primitive bone cells, and it produces osteoids. So this is where it differs from your chondrosarc. So if you get your bone sample and it's got a bunch of osteoid, that pathologist can say, yep, osteosarcoma, and kind of move on. There are different types, and when you send in your bone tumor, you might get back one of these different types: osteoblastic, chondroblastic, fibroblastic, the telangiectatic. A lot of us suspect that those kind of behave a little bit more aggressively. And then, interestingly enough, a path fracture at the time of presentation didn't carry a worse prognosis, which I went back and looked at that again. A lot of these patients could still do a limb salvage surgery, which we'll definitely talk about. They didn't carry a worse prognosis. You can still amputate these dogs, but they are poor candidates for stereotactic radiation therapy and otherwise, surgical stabilization. So these are the patients that you still want to amputate, but they didn't necessarily have a worse prognosis. Metastasis, it happens. It's going to be there whether you can see it or not. So it's common, it's early, it's usually subclinical. So you take your x-ray, you've got your lesion in your bone, you're like, oh, it's probably osteo. Go ahead and just automatically take those chest x-rays. You're probably not going to see anything. Less than 15% are detectable at presentation. So you're probably going to have normal chest x-rays. But if you're that patient who doesn't, if you already have your metastasis in your lungs at the time you come in with your lameness, you're going to do worse. And that's the patient that I may not amputate because I know I'm going to lose him sooner. So take the chest x-rays, look for the metastasis. If you actually see gross metastasis, that patient usually has a poor prognosis. Most of these patients we still lose within a year with metastatic disease. We were discussing this the other night. We talk about it's only a year with osteosarcoma, even with chemotherapy, and it's only a year. It's so short. And then we talk about lymphoma, like it's a year. They have a great quality of life, but it's the same. So I don't come at these patients with this doom and gloom. Oh, we're only going to get a year. This is like, yeah, we're going to get a year. And that might be 7 to 10 years of my life. So if I've got a terrible cancer and someone gives me 7 to 10 years, that might be fine. So it's a year, but it's put it in that perspective of, the dog's life. And a giant breed dog, 9 to 10 years, right? Our average survival. And that might be, a year for them is, a decade, maybe more. So, it can occur to other bones and soft tissues. Generally, when I see it in other bones, I have it elsewhere. So if I'm taking, let's say we're going down our osteosarcoma journey, we've had our amputation, we're getting chemo, and we've got metastasis to the lungs, then I also might see metastasis to, vertebral bodies along the spine. That patient may come in with paraspinal pain or lameness in the other leg, and then I'm taking an x-ray of the spine or other leg and trying to look for disease, but I generally have it in other places too. These axial ones, these mandibles may have a less aggressive metastatic behavior. It's usually a 25 to 30% metastatic rate to the lungs. So these are the ones you can be a little more aggressive on your local tumor control versus maybe all focusing on systemic or something like that. How do they come in? They're usually lame, right? They're lame. Some of them will have a swelling at the site. They'll say, hey, doc, I noticed this bump over, his front leg. Maybe mild trauma. They were, kind of fell off the couch and then they were lame. But 60% of them were lame for a period before presentation. So it's that question of how long have they been lame? How long has it been going on? Oh, they got a little better with carprofen and then they were lame again, but a lot of them were long for some time before they even came to see you. And then a pathologic fracture is pretty rare, less than 3% of all fractures. So it's pretty rare to find it, but we definitely see it. Take multiple views. So this is kind of important. Always take multiple views, and especially on your chest x-rays, I always send just about everything out. These can look very differently. You've got some that are primarily lytic. You've got some that are primarily, just making a ton of bone where they're all osteoproductive. And I always talk about it as, the cancer is eating the good bone and making bad bone. And I think clients seem to understand that when they look at the x-rays. So we're causing these punched out holes. It's eating all the good bone and it's making bad bone. So here's some different kind of presentations. We've got this first one, which is almost all lytic, right? It's just like eating away at this bone on the inside. When I see a primarily completely lytic lesion, occasionally I'm starting to think, is it osteosarcoma? Is that the one I should go get a biopsy on? Round cell tumors, multiple myeloma will look like this. It'll be often like just lytic, maybe a little more punched out in there, but often very, very lytic. So this is one, sometimes I talk about getting a diagnosis first. It depends on the breed, the age, a lot of other factors. So we kind of have to take a look at that. This one's kind of, a little more classic. We've got that osteoproductive look. You've got your proximal humeral, productive and lytic. You can see kind of that punched out little lesions in there. And then this other one is that kind of more completely productive. We don't really see a lot of lysis in here, and it's just like coming right off of these bones. These pair osteosarcomas that we occasionally see. Some of these have a little bit better prognosis, and they do a little bit better long term. So just kind of looking at those and wondering what it is, maybe a biopsy on that as well. So different kind of looks here, right? So we've got kind of that moth-eaten looking at, it's just kind of eaten away. We've still got the periosteal production. What's wrong with this one? So I looked at this and I was like, there's something wrong. It crosses the joint, right? We see it in, distal and proximal here. It crosses the joint, not quite the right bones here. This is not osteosarcoma. Things that cross the joint are almost never bone cancer. So when it crosses the joint, we either have joint cancer, right? I'm thinking histiocytic sarcomas, synovial cell tumors, or fungus. Actually, all of these radiographs are coccidiomycosis. So these are all Rift Valley fever lesions, which look very similar on x-rays. One of the biggest things here is this crosses this joint, crosses into this joint. You can see these changes. So none of these are osteosarcoma. Oh, and then back to that really quick. Where has your dog been? So it's a question I ask almost every osteosarcoma. Have you traveled outside of Florida? Have you traveled to the West Coast? Have you been to California in the last 6 months? Have you been out to Arizona, Nevada, and those locations where this might be a factor? Oh, you lived there for the last 10 years. Oh, okay, let's talk a little bit about, getting a diagnosis, maybe doing a titer. Okay, how do we diagnose this? I kind of think of this in kind of these categories. Cytology, you can use this. You want to use a large bore needle, like an 18 gauge. You're gonna usually need some sedation, maybe some hydromorphone and dexmedetomidine. That's something to kind of keep them still. This works pretty well on those more lytic lesions. I don't think it's great for those more productive lesions. I feel like you can't get through the cortex. It's just so hard. It is very easy to miss the site and get reactive bone. When I'm using this technique, I'm going to put the needle into the lesion and I'm going to take that x-ray and I'm going to kind of see where my needle is and hope I'm in the area I want. And then I'm going to kind of really suction hard, make some slides out of it. Save some slides if you can. If you can make like 10 slides, save 3 to 4 of them off to the side, put them in a box, tape them, don't put some duct tape on them, don't let the pathologist stain all of them. And if you need to, you can stain these for ALP. It's immunocytochemistry. So you need a cytopathologist who can run immunocytochemistry. Your Antec, IDEX labs can all do this, but you can send in your unstained slides and run ALP, or if you send them all together, they need to be separated. So because when a technician at Antec, IDEX, or one of the labs receives their slides, they just stain them all. They just all go in the stainer, right? And you need some unstained slides for this. So save a couple if you're going to do this cytology. And if it's ALP positive, it's osteosarcoma, and you get to move on and you're done. Bone biopsy, there's kind of multiple different techniques. These are all described in the wonderful surgery books out there, kind of these open incisionals, these closed ones, these tree finds. They all have different accuracies. They all have different kind of, ways to get to them. I use bone biopsies when I have a lesion in the wrong location, the wrong breed, an owner who is like, I have to know what this is. I need to know what this is. And I don't want to do anything until I know. Let's go get a bone biopsy. there's a risk of fracture with these. We talk about it ahead of time, and what are we going to do with that? And then let's go get a bone biopsy. Some of these will fall apart as you're getting it out. I think we had that one today, Dr. Ruddle. So she's like getting in there and she's like, it's just gelatinous. I can't get it into the biopsy instrument. It's just falling apart. So we ended up actually aspirating and like curetting some of this out for a diagnosis. And then presumptive. This is my favorite way to get a diagnosis. I just presume it's osteosarcoma until you tell me it's not. This is fine. It's easy to do. It's based on their age, their breed, their size, their clinical signs, their location of the lesion. It's a proximal humerus in a Great Dane, or it's a distal radius in a Great Dane. How it looks on radiographs and where they've traveled to. If they've spent their last 10 years in Arizona, I'm going to look for fungus in that patient. But if they've spent their entire life in Florida, and they're a large breed dog with a lesion in the distal radius, and they're lame, and they're 9 years old, it's osteosarcoma until you tell me it's not. So this is perfectly fine. And I just go through these things with owners. I can do this, I can do a bone biopsy, or we can just presume it is and move on. And that's perfectly fine. Staging. So kind of like, where is it? What's it doing? I'm feeling the regional lymph node when I'm talking, when I'm doing a physical exam on these patients, but it's rarely involved. So if I feel a huge pre-scap on that patient with a distal radial or proximal humeral lesion, I'm going to sample it, but I rarely find it. It's pretty unusual. It's usually not involved. Even when you do your amputation and you send it in, almost always that lymph node's negative. So I don't routinely sample, lymph nodes. I do really like thoracic radiographs. We talked about it earlier. You want 3 views. If there's visible metastasis at the time of presentation, that's just going to do more poorly, and I want them to know that ahead of time. Radiographs are going to usually find something that's 9 to 10 millimeters or larger. So if we need something detecting something even smaller, we're going to go for our advanced imaging like CT scan, our PET CTs, our MRIs, and our bone scintigraphies. So these are just more advanced. I'm thinking about these options when my owner wants a much more aggressive treatment. They want the limb spare surgery. They want the, something else that's just more aggressive that we're going to do a lot more with. Stereotactic maybe, and axial lesions. This might be very, very helpful. So advanced imaging with a lot of these other things, and we're going to use, CT scans primary, before our radiation, help planning. So again, kind of the 3 view. You take your right lateral, oh, it looks great. And then you take your VD, it looks fine, right? And then you miss your last and your third one, and you've got your MET right here that you can see. So take the 3 views, just get all 3 in there and look for the METs. Again, you take your right lateral, and then you take your left lateral, and wow, there's a giant, mass there. So you can definitely miss something with just 1 view. Stage. Okay, so there is a staging system. I don't know a lot of people who, put this down, but it depends on the histologic grades. If you send your osteosarcoma in, your pathologist can give you a grade. It depends on the anatomic setting. So these T1s are kind of within the bone, and these T2s are starting to come out of the bone. You've got your M, which is your metastasis. So has it gone anywhere? So without metastasis, with metastasis. And then lesions, with regional or distant metastasis regardless of grade. So they're already meted, but maybe it's a low grade. Most dogs are a stage 2B. So generally, that's what we're going to see. Prognostic factors. So a lot of people looked at like, how do we determine how your dog is going to do versus all the other dogs with osteosarcoma? So a really large tumor size, as you could kind of expect, is a poor outcome. The proximal humeral location has a decreased disease-free interval and survival time. So when it's up in the top of the humerus, I'm already a little leery that maybe that dog's not going to do quite as well. Under 5 years of age has a shorter survival time. Another study did not identify it as prognostic for the development of metastasis. So, what does that mean? They might not live as long, but they're gonna probably develop metastasis at the same time as the other ones, maybe not any sooner. I've definitely had young dogs do fine. So I've had 2 and 3-year-old dogs come back osteosarcoma. We do the amputation, we do the chemo, and they still get the 1 to 2 year survival time, maybe even longer. I've had a few of them. So while I think it definitely worth a conversation, that we know young dogs might have a shorter survival time, I don't necessarily alter my treatment expectations or plan in any way. I say, let's hope for the best and we'll prepare for the worst. Small breed dogs, it's suggested that there's an improved survival time with curative intent therapies. And I definitely think I see this. I have my little, Westie come in. I had a Jack Russell come in with osteosarcoma. They undergo their amputation, they get their chemotherapy, and they're the 2 to 3 year survivors, oftentimes. So I like to, hope that these small breed dogs tend to be a little bit better. This high histologic grade, it's pretty controversial. And the mitotic index, when your pathologist gives you, your mitotic count per 10 higher power fields, some of these play out as really prognostic. Some other papers have found them not as prognostic. I don't put a ton into it. I do note it. Oh, this pathologist commented that it's very high grade. The mitotic count is over 65, something like that. And it's something I might have a conversation with the owner. Hey, your dog might have a more aggressive tumor type. How does that play into our therapies? We just don't know yet. These extraskeletal locations, like that mammary one, the spleen, those do pretty bad. They have a really high metastatic rate. We often lose them in about 3 months. Excuse me. Stage 3, when they're already in the lungs, right? These are the dogs that have a poor prognosis, as we discussed. Elevated ALP, right? So you run your chemistry and you see that ALP up, you take your x-rays, you've got your osteolytic, osteoproductive lesion. That dog may do a little bit worse when it's above, 110 units per liter. So it correlates with size, macroscopic metastasis. So it's just something I tend to note when their ALP is up. I will say a lot of, these osteosarcoma dogs come in with an elevated ALP. It's pretty common that we'll see that. Osteosarcoma in flat bones, it seems to be okay. So if you can get these, if you can surgically excise these can be better. These can have some positive, prognostic factors. So small dogs, and if you can get these surgically, they can do quite well. I absolutely love, I think this is my, how do we discuss osteosarcoma in the room with the clients? I want them to think about it in 2 big categories. Your definitive therapies, I called it the I want to kill cancer cells definitive therapies. Let's kill the cancer cells. Let's give them the longest survival time. And my palliative therapies, I just want to make them comfortable. That's it. I don't care. I do care how long they live. I want them to be comfortable. That's my primary goal. If they live long, great. If they don't live long, that's perfectly fine. But my primary goal is comfort care. Okay. I really need my owners to honestly decide between one of those 2 therapies. That's their goal after my consult, is to go home, think about this, and decide between kill cancer cells, make them comfortable. And once they've done that, I can provide all these options and we could do things. But until they've made that decision, it is difficult. So give them these options. Where do you want to go? Kill all the cancer cells, try and kill all the cancer cells, or go with palliative. Okay. So in our definitive therapies, we've got local treatments, the primary tumor, and then we've got our systemic treatments where it wants to metastasize and go everywhere. So we're going to, focus on those 2 things. In our palliative, we want pain control. That's it. We want comfort. We want to make them comfortable. Okay. So let's break it down. So in our local, on our definitives, we've got some sort of treatment to the primary tumor, which could be surgery. And in surgery, we have 2 options. We have amputation and then a limb spare or limb salvage surgery. And then also we've got stereotactic radiation therapy. So great form of local control where we can really reduce, tumor burden. In our systemic therapies, that we've got 2 options here as well. We've got chemotherapy and now a lot more immunotherapy options that we've been working on and now coming out. So surgery as far as limb spare goes. So these are select cases. These are cases that you really got to have to kind of look at ahead of time, and are you the best candidate? You want the primary tumor to be less than 50% of the bone, and it can't be like a 360 involvement of, soft tissues. This is often evaluated on a CT scan, sometimes an MRI and a CT scan, where they'll basically say, okay, the primary tumor is 30% of the bone circumference. It's, 40%. Those ones that are all the way around don't work. These aren't the candidates for those limb spares. The distal radius and the ulna are the most suitable sites. And really, as you can see in this picture, it's the ones you can arthrodesis, right? It's the ones where you can plate across that joint and that dog can still walk. So the stifle is a really hard joint to plate across, right? It's got to move. It's got to kind of bend and stuff. So it's really hard to kind of plate across. They've definitely done it in some cases, and some dogs have done pretty well with it. But this, that distal radial site is one of the better ones. There are a lot of different procedures described. There's these allografts, these metal endoprothesis, but the basic gist of it is cut out tumor. Sometimes they irradiate the space afterwards. Put bone in, and then plate across it so it can be stabilized. So cut tumor out, put something in, plate across, stabilize it. Let me see if I've got it in here. Oh yeah, no, let's talk about it. Many of these patients developed postoperative infections. And interestingly enough, those patients that developed postoperative infections had a better outcome. So just because you get an infection after surgery didn't mean you were going to do badly. It actually meant you were going to do better. So it's interesting in these cases. So we'll see a lot of postoperative infections. These are your dedicated owners that want more. They want to keep the limb. They don't want to lose the limb. They want, kind of a more treatment. They're your patients you're going to refer to primarily Colorado State, University of Florida. Those are great places for this. And then they're going to do more advanced imaging to determine if they're really good candidates for it. So definitely an option. They get to keep their limb. They remove the primary tumor. They're much more comfortable. They're often walking around pretty well. Amputation, you guys do all this all the time. They usually function just great. One study looked at it that they were 88% same or near same quality of life after amputation. So if your owner needs that quote or that number, 88% of them do the same, after amputation. 73% return to pre-amputation activity level. So they run, they jump. I have a lot of them swim. Sometimes they swim in that circle and they kind of go around and around, but that's okay. It may progress more rapidly in three-legged dogs. So your osteoarthritis may progress more rapidly, but it rarely results in a clinical problem. So you've got your patient comes in, we amputate. Oh, he has arthritis in the other knee. He's got arthritis in the other hip. He's got this. It might progress more rapidly, but it rarely results in a huge clinical change on your part, meaning they're often still going to die from their osteosarcoma, not their OA in the other limb. Physical therapy, rehab, we're doing a lot of that post-operative, getting them into these clinics, getting PT done, and they're doing great. I always still recommend some sort of complete four-quarter amputation for thoracic limb and coxofemoral disc articulation. You want to be far away from the cancer as possible. So these mid-humeral or, mid-femur, you're still close to the tumor. You might leave disease behind. I have definitely seen, stump sarcomas form all over where, a mid-femoral amputation was performed. So you want to be farthest away. If you can do that with these, coxofemoral disarticulations, that is ideal. And just kind of, consider it. Those proximal femorals, there was a group that looked on these, en bloc acetabulectomies. I'd have to ask my surgeon about that. How feasible is this? Can you just scoop out the acetabulum while you're in there? I don't know. I'll have to, talk more about it. But a paper did definitely look at that for those proximal femoral cases. So that leads us into the other local treatment control. So we've talked about surgery options for local treatment control. And now we've got, what is our other option? I don't want to lose my leg. I can't do limb spare. I can't travel to Colorado for that. Let's think about stereotactic radiation therapy. So this is the patient that I want to keep the leg, doc, but I want to be as aggressive as possible. Okay, this is your candidate for that. So it's also called stereotactic radiation surgery or stereotactic body radiation therapy. Honestly, my radiation oncologists have told me all the differences between these terms. They have told me when to use it, when it's appropriate, which time, and I still can't figure it out. So I put them all on here. It's all in there. So SRS, SRT, SBRT. It's going to be right there. So it's one of those. I'll have to ask Dr. Lyons exactly which one he likes. I think it's SBRT, but I have given up on trying to learn exactly what the difference is between all of them. So some sort of stereotactic radiation therapy. Basically, I think of this as high dose radiation to the tumor while not affecting the other normal tissues. So we're not trying to kill all the good cells, we're trying to kill all the bad cells. It is considered a non-surgical limb salvage technique. So we're, not doing an amputation and we're trying to salvage our limb. This is not palliative radiation therapy, which we're going to talk about in a little bit. This is stereotactic high dose radiation to the right where we want it to. The first studies, I want to say came out of UF, but I'm not actually sure. But there was a study of 11 dogs, and they did kind of a single fraction of SRS and some carboplatin chemotherapy immediately prior to the radiation. The limb report was excellent. So these dogs come out and they use their legs. They did force plate analysis. They kind of looked at how they use their legs, and they said, oh my gosh, they use it great. Their median survival was fantastic, right around a year. So they said, oh my gosh, we got to do more studies like this. So they enrolled another study. They did 46 patients. They did, again, that single fraction. So one treatment, so one single fraction of SRS. And then a few of them, 45 of them, most of them received chemotherapy as well. Their median survival was less, 9.7 months, and 63% of them did develop pathologic fractures around that 6 months. And some of them had a little bit of acute skin toxicity. This was done before our machines were even better. So we actually have better technology, better linear accelerators. We can be more accurate, and the skin toxicity has gone down quite a bit. So this is something we saw with our a little bit older technology, but still reported and interesting. The kind of more recent study came out of CSU. It was a pretty big study, 123 patients. They did 3 fractions. So this is 3 treatments, 36 gray and 3 treatments. Some received bisphosphonates like zoledronate, but none of them had chemotherapy. So this was all, just done as an SRS paper. 84% had improved lameness scores at 3 weeks, which is pretty quick. So you have this limping, lame dog, you go and you get your SRS, and 84% of them are better. Many had it for an increased time, almost 6 months. I generally say it can be anywhere from 2 to 10 months where they'll get that improved lameness. There was a 41% fracture rate. Them having a prior cytology or neocore biopsy did not increase their fracture risk. So they looked at the dogs who all had some sort of diagnosis, bone biopsy ahead of time, and none of them had an increased risk of fracture. Median survival time was only 233 days, and maybe it's because none of them had chemotherapy, and we focused on primary, local treatment control. Many of them did have a salvage amputation after their, pathologic fracture. And those patients that did this had an even longer survival time. So think about it this way. You don't want to amputate your dog's leg. You go ahead and do your SRS, SRT, and you get improvement. And then months go by, 6, 7, 8 months go by, and your dog does develop the pathologic fracture. You can still amputate that. You can still go for an amputation, and those dogs even lived longer. So it's very interesting, especially for those clients that don't want to go for an amputation, go for this, knowing that if something happens and they do fracture, you can still amputate that leg, and they can still have a good outcome. Presence of metastatic disease at the time of diagnosis, at the time of treatment, did not impact survival time. So again, this patient who doesn't want to amputate, they maybe have metastasis, but we want to make them more comfortable, their lameness improved. We want to, you know, try something. SRS, SRT is probably the way I would go with those cases. And where do we do stereotactic radiation therapy? We do it down with Dr. Lyons in our Fort Lauderdale office. So here he is with a couple patients from a little bit ago. What he's probably going to talk to them about is a CAT scan, CT scan for planning purposes, right? He's going to plan to, again, target the tumor, avoid the normal tissues, avoid the bone. It usually requires some sort of heavy sedation, general anesthesia. A common course is that 3 fractions, either daily, like Monday, Tuesday, Wednesday, or every other day, like Monday, Wednesday, Friday in a week. So it's often done in a week, either daily, every other day. Some of these patients are getting chemotherapies. Some of them are getting bisphosphonates. That's up to clinician preference, owner wishes, things like that. The radiation side effects are very minimal. I almost say they're none. I don't expect nausea. I don't expect vomiting. I don't expect diarrhea. We're only treating where the bone tumor is. We're not treating the whole dog. So they get a little bit of, you know, scale along their skin, a little bit of darkening, little hyperpigmentation to where it is. And that's really it. That's it. We don't almost see anything else. It might grow back. The hair might grow back in like white or a little gray. It often happens many, many months later. But these dogs feel fine. They do undergo a brief anesthesia or, you know, or sedation for the treatment, but they do great. Here's some different plans. Dr. Lyons allowed me to kind of utilize. This is a distal humeral lesion. You can see this down here in this, I think it was the golden. So again, 3 fractions, 11.5 gray. It's a total administered in 1 week. So often, again, that Monday, Wednesday, Friday. So they're coming in just 3 days a week, undergoing a brief anesthesia, radiation to the distal limb, wake up, go home. So he uses all that imaging from his CT scan to help plan the radiation. So he's going to say, okay, I'm going to color. I call this advanced coloring, Dr. Lyons. So he's going to use his fancy colors, and he's going to go right around his tumor, and that's going to be his gross tumor volume. And then he's going to say, okay, I want to treat this area, his planned tumor volume. And then he's going to make even colors. Okay, I don't want to treat these things. I don't want to treat the skin. I don't want to treat these other areas. And those are going to be his different colors. Then he's going to set this up on a dosed volume histogram. And his machine is going to spit out, okay, this line up here is going to be, we're going to give all this dose to the tumor, right? So a lot of dose to the tumor. And then this is our skin down here. We get very, very little dose to the skin. And that's how we can avoid those severe burns and those lots of side effects we used to see with our old machinery, with our cobalt machines and things like that, where we had, you know, kind of the burns on the face and they were, you know, eaten away with radiation. So we're now so fantastic. I mean, there's almost no dose to the skin. So patient setup, we're in a vac block device. So this little vacutainer, they get their own little bag and they make it up for their own little leg and their head's in here. And so they're going to get their radiation delivered to this, you know, distal radial lesion right here. Again, wake up, go back home. I'm not sure if this video is going to work, but we're going to see. So this is going to show our multi-leaf collimator, our MLC. So this is basically where that MLC is going to kind of, I'm going to try this. Nope. Okay. So basically that picture was showing kind of the different leaves we're going to move and show, and they're going to kind of go around and make the tumor. So they basically kind of block the beams from coming out in different ways to kind of form and conform to the tumor. So it's kind of really neat. And goes right on there. So let's go to the next one. I, again, don't think this video is going to play, but this is the patient getting treatment down in our Fort Lauderdale office. So that machine's going to move around the leg, and we're going to kind of get movement, and to target everything we need. And it can go 360 around and get every inch treated while, again, sparing all the normal tissue. Okay. We're going to move right on into chemotherapy. So we've kind of talked about our local treatments. Now we're going to talk about our systemic treatments. So Lots of research done in this. Carboplatin really has largely replaced cisplatin over the years. It's easier to give. It's, less nephrotoxic. So basically, we're all reaching for this. A lot of the very early studies were all done on cisplatin. So, but carboplatin has kind of replaced it completely. I can't remember the last time I gave cisplatin, maybe 6 years ago, maybe. So a case looked at about 48 amputated cases. They all got about 4 doses. Their disease-free interval was just over a year. Median survival time was close to 2 years. So they do great. So you amputate them, and then you give some chemo, and they did pretty well. Doxorubicin. One study noted better results every 2 weeks than 3. You can get every 2 weeks and then go forward. I honestly, when someone asks me what do I pick, I usually pick carboplatin, honestly, because of the ease of administration and maybe less side effects than doxorubicin. But as far as survival times go, they're very, very similar. So you've got an oncologist who uses primarily doxorubicin. You've got an oncologist who primarily uses carboplatin. Some combine them. Here you go. There's a study that looked at, both combination doxorubicin, carboplatin, and that wasn't superior to a single agent, so a lot of us kind of fell off this one. But again, this one was closer. So carbo with alternating doxorubicin every 3 weeks, doing 3 of each, so 6 total. That median survival was, again, right around a year. So, fairly similar outcomes with chemotherapy. I basically say just do some chemotherapy of some sort after your amputation. Excuse me, thanks. Okay. Chemotherapy, and then what do you do after chemotherapy? So you've given your 4 to 6 doses of carboplatin, and then my owner says, what next? And so some studies looked at piroxicam, cyclophosphamide. They had, or in combination with their chemotherapy, they did have more toxicity, and there wasn't really a difference in disease-free interval. I will often have my patients on an NSAID. If they come in on an NSAID like, Carprofen Deramax or something, I'm not going to change it. They're already on it. They're usually doing well. If they're not on one, I might pick piroxicam, mostly because all the studies were done in it. But it really is what they tolerate for their GI effects. But really, it didn't change their disease-free interval. A lot of us tried metronomic, cyclophosphamide and meloxicam, post-amp and carboplatin. There was an increased risk of sterile hemorrhagic cystitis, 58%. A lot of these dogs got sterile hemorrhagic cystitis, so it's definitely a conversation of if we're going to do some metronomic oral Cytoxan in your patient after your chemotherapy, after your carboplatin or your doxorubicin, we really might get this, but they did have a longer progression-free survival time and median survival times. And it was longer than those without maintenance. But it wasn't significant in that paper. So interesting, but so something I definitely have a conversation about. So we finish up our 4 to 6 carboplatins, and then we say, okay, do we want to do any kind of maintenance therapy? Do we want to go on Cytoxan? Do we want to go on chlorambucil? Do we want to go on something else? Here's a risk. We can think about this as well. All right. Okay. Targeted therapies. Palladia, we were all excited about this. Can we use this in osteosarcoma? It came out for mast cell cancer, and we're like, can we get this done? So a study looked at this. We had an amputation, 4 doses of carbo, and no statistical difference. So these dogs didn't really do any better. So a lot of us stopped using Palladia for osteosarcoma. It wasn't really different. But a study just came out, or a cell culture study just came out with combining it with losartan in already metastatic lung osteosarcoma. So these are the patients with already metastatic lungs. They looked at losartan, so that, blood pressure drug, with Palladia, and there was significant biologic activity in dogs with metastatic osteosarcoma. So I'm probably going to try this. So this is the dog that comes in, it's amputated, it's had chemotherapy, it develops its pulmonary mets. I'm probably now going to try some Palladia with losartan and watch their blood pressure. I am sorry, I'm moving slowly. I'm going to go faster. Okay. Biomarkers, I put this in here because this is where our targeted therapies need to go, and I really need to get to immunotherapy. So let's do this. Okay, immunotherapy, this is what you're here for. We first looked at liposomal encapsulated. You can't get this anymore. So sometimes your owner will come to you and say, hey, I read about this on the internet. We can't get this. I have yet to see it be available. HER2/neu was very exciting. We were all excited about this listeria fused vaccine that was towards HER2/neu and osteosarcoma. Unfortunately, in the study, a dog patient developed and cultured live listeria out of a rib met in 2019. And then unfortunately, there's a huge zoonosis potential. So this was largely abandoned. So this is also not available. So Elias ECI, cancer immunotherapy. This is the new thing that's out here. It's an adoptive T cell therapy. We've got 2 phases, a vaccination phase and then a T cell infusion phase. So Elias is very receptive to questions. If you have a lot of questions, concerns, they're wonderful to work with and easy to talk to. So just if I can't get through this fast enough, just wrap up with them. Okay. It's a combination approach. And so again, we've got this vaccine, and then we're also going to infuse T cells that will help attack cancer cells is the basic way I think about it. So we're going to, great. Yeah. So all the studies come out of these other trials done in humans. So we did a bunch of trials in humans with renal cell carcinomas, malignant gliomas, and they said, hey, this is working. Let's look at it in dogs. Okay. So the preliminary trial looked at this, and a lot of dogs had these really long-term survivals. They had like 2 to 5 year survival time. So they said, oh, we've got to go forward with this. It was a small trial. Then they did their pivotal trial, which is 100 dogs. I think I had 2 in this one, and it was just really neat and wonderful. This should be published later this year. So you'll probably see the data come out on this. And then we're going to expand into other kind of cancers. Okay. So again, those long-term survivals live 2 to 5 years, and then we're going to see how to go through this. Okay. So that initial 100 dog trial, you need a dog with the osteosarcoma still in place, not amputated. Send it to me. Not amputated. This is not a study right now. This is the prior study I'm talking about. It is currently not in study. So if you send me one right now, this is a case that is basically not in trial. This is a treatment now. Okay. So comes to me, still has its leg. They need to be able to go through this 6 to 7 week treatment, but this in the study, these were the requirements. They weren't on a bunch of pred. They needed to be off their some sort of herbal supplements and things like that, and they didn't have any other concurrent malignancies. You amputate them, and you send in the tumor, sterilely collected by your fancy surgeon, into a collection device, and you send it to Elias. They send in the rest of the bone for analysis, and you get your pathology report. You determine, yes, it is osteosarcoma. So the surgeon collects your 1 gram of sterile tumor, and they send it in, and Elias makes you this lovely vaccine. They ship it to you, ship it to me, and then we start doing these intradermal vaccines. You give them near lymph nodes, okay, so prescapular regions, popliteal regions, and you give them near lymph nodes in an intradermal technique, okay, and it triggers the immune system to start working. Okay, let's see, this is my tumor, this is my osteosarcoma, and I'm going to start to be triggered against it. You're going to give them once a week for 3 weeks after day 7 from surgery. And then we're going to have an apheresis. Okay. What we're going to do here, we're going to send our patient to an apheresis center. Right now, Blue Pearl in Maitland is going to be our apheresis center. And so we're going to send some cases there, and they're going to undergo apheresis. This is done under anesthesia. This patient needs to be under anesthesia for approximately 4 to 6 hours. So this is a patient with a good heart, with good lungs, with needs to be able to be under anesthesia for quite a while, or at least heavy sedation. So they go into the apheresis center, and they're basically going to collect blood for 4 to 6 hours, right? We're going to take out all the T cells, and we're going to send them to Elias, and we're going to give back all the other cells. So they're coming out fine. Some of them will stay a night after the collection for recovery. Some of them will go home right away. Totally depends on the patient. So they come in, they're sedated, they're under anesthesia, they have their apheresis for a few hours, take out T cells, send them to Elias, and we're going to expand them. And basically, we want all the T cells that were made towards the cancer cells pulled out, and we're going to expand them. Then we're going to give it back to the patient. So we're going to give all those good T cells, those regulated T cells, back to the patient. So we do T cell infusion after that. Okay, so they're going to come back into the office. Their T cells are grown up. We're going to infuse all of their killer T cells back into them, and they're going to expand in the body. Then we're going to try and stimulate those T cells even more with some IL-2 injections. So the next 4 weeks, we're going to give some IL-2 injections. So these are subcutaneous injections. It's a low dose. We aren't seeing the significant side effects with it, and it's being done. I actually gave one owner these to take home. She was a nurse. She said, I can give subcutaneous injections. And I said, here, take these home, give them, over these next few weeks, and it will go great. Okay, so here's a typical schedule. So they come in, and we screen them. We talk, or this was the schedule of the study originally, but they come in, we talk, we do the chest x-rays, right? We don't have metastasis. We think it's bone tumor, right? But our limb is still there. We haven't actually, some of them may have had a biopsy, may have confirmed, but a lot of them haven't. They're just still there. They're gonna have surgery. That surgeon is gonna collect tumor, send it to Elias for vaccine development. We're still going to send in the rest of the bone for pathology analysis. I want to know that it's osteosarcoma. If it's not, I want to tell Elias that it's not osteosarcoma. We're going to do something potentially a little bit differently. Then we're going to get our vaccine shipped back to us a week later, and we're going to start our vaccination series at days 7, 14, and 21. So weekly vaccinations in those little lymph node sites, basically. Then at week 4, we're going to have our apheresis. We're going to draw out all of our good T cells that we've developed. Then we're going to put them back in our patient the next week, and then we're going to do our low dose I-12. Okay, so it went well. So these patients had, longer survival times. They went quite well. The question is, do we do chemotherapy with these patients? And right now, if you're going to do chemotherapy, we're going to do it ahead of time, not after. So these patients, these are the clients that don't want to do chemotherapy. They want to do a lot of standard of care. They want to do everything, but they don't want to do chemotherapy, and this is what we're going to offer them. These are the clients that come in and they're like, yep, I'm fine with an amputation. I don't want to do chemotherapy. What else do you have? Yes, let's try immunotherapy on top of this. It is not a current trial. This is a, client funded at this point. I would anticipate with an amputation, with Elias ECI therapy, with all of these treatments, that these are the patients probably going to spend the 10 to 20,000 range. This is your dedicated owner. They want to do everything at every time. Okay. Palliative, really fast. We'll go through this really quickly. I have 3 options: palliative radiation therapy, bisphosphonates, and analgesics. Palliative radiation therapy, often 2 to 4 fractions. So maybe 2 times, maybe 4 times, maybe weekly, maybe back to back, maybe 1 to 2 days. It alleviates bone cancer in 74 to 93% of these dogs. It is one of the most effective treatments for osteolytic bone pain in human cancer patients. If you've got a friend who had, a bone met, or yourself, and you got radiation to it, it was the most effective treatment for osteolytic bone pain. So this helps with bone pain. Its median survival times, or median interval of the improvement is anywhere from a couple months. I usually say like 2 to 6 months. And they really don't see any side effects. We don't see those bad burns or anything like that. They feel great. Aminobisphosphonate, zoledronate is the one I'm going to use. We're going to go towards basically try and kill those cells that are eating the bone, and try and, keep that more comfortable. So if I can kill the cells that are eating the bone, and they're going to feel better. So decreased bone resorption. Pamidronate was our old drug. Zoledronate is 100-fold greater anti-resorptive potency. So we've pretty much all gone to that. So it's just a better, newer class of drug. There was one report of jaw osteonecrosis in a dog treated monthly with zoledronate for 43 months. Why you want to give something, a drug for 43 months, I'm not sure, but you might develop osteonecrosis in that dog. I generally say this is incredibly well tolerated with no side effects. I do check their kidney values while they're on it, but they do really, really great with it. You give it once a month. So again, for those patients who are like, I don't want to do amputation, I don't want to do SRS, I don't want to do the definitive treatment planning, I want the palliative, I want to make them more comfortable, zoledronate, palliative radiation. And then just a quick on my pain meds, what I usually reach for, I'm going to reach for an NSAID first. I'm going to add in gabapentin. I'm going to add then an amantadine. I don't take away, I add. So once I can't control that pain, I add to it. Tramadol, I'm not sure. Numerous studies, really variable response in dogs. Does it work? I don't know. I do think it works in some patients. Some patients really come in and they're like, Tramadol is the best thing for my dog. And I believe them. But then in some dogs, I just don't know that it works at all. I think it causes more sedation and I leave it out. If they're through these drugs and painful, I'm going to drop out my NSAID and go to acetaminophen codeine. So I'm going to write that controlled substance script and I'm going to send them home on that. If they are miserable and we're towards the end and I cannot control that dog's pain, I'm going to put a fentanyl patch on. But these are for my late stage, I can barely get up, but doc, I can't let go patients. Okay. Palliative chemotherapy, I don't usually do it. When I'm in the palliative mode, my focus is pain control. So I'm really not reaching for chemotherapy drugs. There's a study that suggested it's really not efficacious for that dog with that big bone tumor, in the proximal humerus. It doesn't really work. There's some thoughts on some HDAC inhibitors, valproic acid. So definitely not wrong. Maybe not something I'm going to think about. Again, palliative, I want it more comfortable. Definitive, I want to kill cancer cells. Prognosis, what do I tell people? When we just do an amputation, they usually live 4 to 6 months. They usually are going to die from pulmonary mets. Amputation and a limb spare and an SRS, it's about 12 months, 20% we're at 2 years. Amputation with immunotherapy, we'll see. We'll see where we're going to lie on all of that. Palliative options, they're probably going to come to the local tumor, not metastasis. These are the patients that I'm going to die from pain or a fracture in the tumor, not necessarily metastasis. They have wide ranges. I often don't give them a time because it really depends on how that tumor affects that patient. Some dogs have a giant tumor, walk around and could care less. Sometimes to have a, barely lytic lesion and they can't walk and they're miserable and they stop eating. So it's really different. Okay. This is my own dog who had osteosarcoma. I actually did palliative radiation. She developed a oral melanoma with meds. But she actually had great pain control from her palliative radiation. So, okay, I think I am ready for questions. Sorry, I went a little long and I'm really sorry. Okay.
Wow. I don't know how you got through all that anyway. I mean, it's a huge subject. I mean, it's like to cram in 1 hour. So, kudos to you. We got a couple of questions in here. And I got to admit, the first question that popped up was one that always ran through my mind when I was in practice is, can I cause a pathologic fracture with a bone cytology?
Ooh. I don't think I put it in my thing. There is a study that looked at the percentage of pathologic fractures with cytology, and it is so incredibly low. Can you? Yeah, you can. It can happen. Have I seen it? No. I really haven't. I would have said that dog was the one who would have fractured anyway. It was probably going to fracture no matter what. So do I talk to them about the risk of it? No, I didn't have the percentage in there. I talked to them about the risk of it, but it is not something I dwell on, especially with a 18 gauge or something like that. If I mention it, I don't dwell on it. I don't think it's a significant impact, in those cases. So it can happen. It can happen with anything. So my approach to pathologic fracture is, well, it could have happened from my needle, but it also could have happened while the dog was sitting there. So it can happen at home. It can happen walking up the stairs. It can happen getting out of the car. It can happen while doing anything. So I don't change my approach because of a pathologic fracture. And I will tell you, I don't limit these dogs from living their lives. So people come to tell me I can't let him walk anymore. I can't take him anymore. No, does he like doing that? Go. So does he risk a pathologic fracture? Yeah, but he also risked it laying down on the floor and he risked it, getting up that day. So he risked it no matter what. I live their life. So you just have to be prepared what they're going to do in that moment. When they get the pathologic fracture, I can't fix it. It's either an amputation or euthanasia. So they just have to be prepared for that eventuality of what happens, which you can always still remove the leg. Great question.
Well, that's good. I know that popped through my head several times when I was biopsying these things. I'm like, oh dear Lord. So I got another question. It says, are there anti-angiogenesis effects of NSAIDs?
We still believe that. So those COX-2 inhibitors, we still believe they're anti-angiogenic effects. How much does that play into bone osteosarcoma? Maybe for pulmonary metastasis or disease in the lungs, but there's not a ton of blood vessels in our, there's blood vessels in our bone, but how much is that going to play into their response? Yes, maybe. I still use them. I use them for anti-inflammatory effects and pain control and other things. So I'm still going to definitely reach for them. Yes, it happens. How much does it play into osteosarcoma? I'm sure there's a good paper on it, and I'll probably try and go find that.
Right. Well, in pain management, you're going to use it most likely anyway. So it's going to be on board. So, makes us all feel better. Maybe there is a little bit, I don't know, of effect there. Okay. So one of the other questions that popped up was, what prognosis do you give patients who choose to do no treatment?
I think this one's hard. This one's variable. So they come in, it's probably osteosarcoma, it's the right breed, right location, and they're not like, I'm not doing anything, doc. That dog could live 2 to 7 to 9 months. And I don't know where it's going to be in there. It depends on how that cancer affects that dog. And they're all individual. And this is where I struggle because, well, you told me it was going to, you told me he was going to die 6 months ago, doc, and he's still alive, and so this is the one I don't necessarily give them a definitive answer. It really depends on how it affects that dog. So if they come in super lame and they're miserable, that dog's not going to live as long, right? Even with, your carprofen or whatever. But if they come in and they're fine and you find a lesion, I don't know. It might be a long time before that lesion affects that dog. Very individual. You've got your pit bulls who get an osteo and who could care less. Run on it, they jump on it, they jump over fields of stuff and they don't care one bit. And then you have, a Ruddy or Golden come in and it's like, I'm dying. I can't move anymore. I can't do this. And so it depends on how that lesion affects that dog. And so I give them a really wide range when they're not going to do any particular therapy.
All right. And then and this looks like it's going to be our final question. It looks like, and of course it's kind of always the tough question, doc, right? Is how much does the Elias ECI therapy cost?
Yeah, I think I briefly went through this. So this is your dedicated owner. And this is your dedicated owner who's like, I really want to do everything. I want the most cutting edge therapy that's out there for us. So our amputation, probably 4,000 to 6,000. Then we're going to go through our immunotherapy again, and probably an additional, 3,000 to 5,000, with apheresis being another 3,000 to 4,000 on top of that. So it's a big chunk of change. It might have improved survival times than everything we've done so far. So we will see. But it's something for those patients who are, I want to do everything. I don't necessarily want to do chemotherapy. What else is out there for my pet?
All right. Well, that's going to wrap us up for questions for tonight. Remember, in the next 24 hours, you'll get your certificate for C. Dr. Ruth, that was an incredible talk. Like I said, I'm still amazed how fast you got through that. And it's a huge subject. So really, yeah. I think a great way to start off the Cancer Summer Series. Awesome job. And I know everybody else listening was just as thrilled as I was. So on behalf of Merck Animal Health and Animal Cancer Centers, very happy you guys could make it tonight. And we will see you in July for the next one.
Thank you so much. Thanks, everybody.